Hello, my name is Marc Ryan. I'm the Chief Strategy and Compliance Officer for MedHOK. Welcome to one of a series of podcasts on the healthcare landscape. The title of today's podcast is The Emerging Value-Based Healthcare Environment. As everyone is well aware, there is an emerging value-based purchasing environment in the United States healthcare system. This is very much driven by the fact that the Centers for Medicare and Medicaid Services, known as CMS, is becoming the de facto national healthcare policy czar and leader of all healthcare policy in the United States. This is true really across all of the lines of business. CMS directly oversees Medicare. CMS has always led the Medicaid program in concert with states and is taking a much more active interest in the policy affairs, given some very poor quality and other standards in the Medicaid program over the last many decades. And lastly, with the advent of Obamacare and the exchanges, CMS also is the lead entity with both the federal and the state exchanges from a policy and financial and rate-setting sense. So while we don't have a single-payer system of healthcare in the country, as the vast majority of other developed countries have, we are seeing a move toward national policy making with a private delivery system. CMS will undoubtedly push this emerging value-based purchasing environment across all lines of business. For the most part, Medicare has really led the advent of this value-based purchasing environment, but for various reasons, this will also come to Medicaid and the exchanges. So let's talk about Medicaid for a couple of minutes. Just recently, over the last several months, CMS published what's known as the Medicaid Uber Rule, which will bring a whole bunch of new policy and regulatory dictates and an absolute new paradigm or framework for the Medicaid program. Most of those regulatory changes are very much modeled after what's been going on in Medicare over the past many years, as much as a decade. The exchange, again controlled by CMS, is beginning to see a fairly robust regulatory environment and value-based environment taking root. For the first time later this year, for the welcome season for 2017, there will be star ratings, for example, on healthcare.gov, which is a big sign that the same environment is moving into the exchange. Let's talk about components of value-based purchasing for a minute, again, led by Medicare for the most part. In our mind, there's many definitions of value-based purchasing, but this is what we see as really driving CMS currently and over the next several years. First, compliance and best practice requirements must be adopted and followed by plans. Number two, tying the revenue that plans receive to quality. And number three, given some very tight rate environments out there, not only in the Medicare but in the Medicaid and exchange world, CMS and states want to align payments to plans by population acuity, meaning those with beneficial selection will receive less dollars per member per month as compared with plans who have adverse selection and high population acuity, which will get a much greater share. And this is done through the mechanism of risk adjustment. Let's talk a little bit about how MedHOK enables health plans and other risk-bearing entities to succeed under this emerging value-based system. First, when it comes to compliance and best practice requirements, MedHOK has a full-time compliance and product team, over 30 strong, that work every day to ensure that all of the on-the-book compliance requirements are mapped into our system out of the box to ensure that plans and other risk-bearing entities stay compliant. And more importantly, we try to map best practice into the system as well. We have experience with hundreds of CMS and other regulatory audits, such as Medicaid and state insurance department. And there we're able to garner what is known as sub-regulatory guidance. This is the kind of things that auditors would like to see plans do as a best practice, but will likely emerge as regulatory requirements in the next year or two. So we aggressively go after and gather these best practice and sub-regulatory guidance from audits and incorporate them into our system as well. Lastly, we have an intelligent workflow that triggers the right kind of workflow, the right kind of business rule based on that given line of business. And we also have an embedded correspondence generation, all of which makes sure that, and it's very transparent to the user, that an individual in our system is able to trigger the right correspondence and follow the right workflow to remain regulatory compliant throughout that case decisioning. When it comes to tying revenue to quality, it's important to note a couple of things here. One, increasingly, drug measures and pharmacy quality performance is as important as medical quality and performance. So plans must really look at these together and not in silos. Number two, while clinical measures remain one of the dominant forms of measuring the performance of health plans, both on the medical and the pharmacy side, survey and other member experience measures, as well as the administrative performance measures of the health plan, are an increasingly important part of quality appraisal and revenue allocation in this new world of value-based purchasing. What MedHOK does is has a holistic single platform with a comprehensive 360 member that allows all users to work in the system to has the most up-to-date real-time information as possible on the member and as much information as possible across all of the clinical and other administrative areas of the health plan. This clearly helps all workers in the system, whether they be nurses, care management nurses, or those dealing with appeals and grievances, to know as much about the member, to communicate with other users, to target problems that are occurring, and to more quickly decision cases and take care of grievances or other complaints. Secondly, we're a strong believer in integrating quality throughout the entire enterprise of the system, and our single platform does just that. We push quality care gap measures into our module for intervention. We push quality care gap measures that are non-compliant into the care management area as well. And we prize ourselves on intervention year-round to ensure that clinical non-compliance is dealt with as quickly as possible so that plans can close out these care gaps and have the highest scores possible. So again, in this area, we focus on tying quality into the entire platform. We focus on holistic intervention, and our Member 360 allows the greatest amount of information in the system so that individuals, associates, health plans, and other risk-bearing entities can really understand exactly what's going on with the case and with the member. On the risk adjustment side, we also tie revenue opportunities on the risk adjustment side to all of the experience in the system. So we have robust enrollment and financial reconciliation processes. We can easily notify providers not only of care gaps to tie revenue to quality, but also notify providers of revenue enhancement opportunities in the risk adjustment arena to ensure the greatest amount of risk adjustment revenue coming to the plan as well. Let's talk a little bit more about two twin pillars and things happening actually in the Medicare environment. But it's important to remember, as I've pointed out earlier, that this regime, both on the compliance side and on the quality side, will also be coming to Medicaid and exchange in the future. Let's take a look on the left-hand side of the slide for a minute as it relates to the compliance regime. First, the compliance regime that CMS is working in for Medicare Advantage and Part D plans really came out in 2012. But since 2014, this compliance regime has really been put on steroids. And CMS is aggressively going after plans for not following regulatory dictates. In many cases, they're very frustrated because they've really built a roadmap for plans do a better job and look at these non-compliant areas. They've published their results of their audit findings. They've published civil monetary penalty letters. They've even published best practice memos that really help and guide plans in terms of how they can improve overall compliance. But unfortunately, the level of civil monetary penalties are increasing dramatically. There were 71 civil monetary penalties since January 1, 2014, with over $18.7 million in fines, and the number of suspensions of enrollment and marketing has increased dramatically as well. Penalties are hitting some of the biggest and most prominent players. So this is not isolated to poor compliance performance just on small and medium-sized plans. It again is hitting some of the biggest players out there. This goes across all plans in terms of compliance records. Let's look a little bit at what the heightened area of focus and interest are for CMS. Well, first of all, the old world of timeliness is still on the table. And I would note that concentration on timeliness is becoming even more complex than it originally was. Not too many years ago, it was not unusual for CMS auditors to look just at the time that an authorization or an appeal or a grievance was decisioned or closed out or resolved. Now CMS is basically saying you have not had a timely decision unless 3 or 4 areas of interest are met. First, that decision date or resolution date or close date, number 1. Number 2, when was the member written confirmation or correspondence fulfilled? Was that within the decision date and time? Number 3, provider written communication and correspondence. When was that done, and was that within the SLA date and time? And finally, in the case of approvals in the pharmacy and in the medical world, was there an effectuation of that authorization or appeal, for example? So unless you meet all of those conditions, 3 in the case of some, 4 in the case of others, you are not going to deem to have a compliant case in those situations. So again, far more complexity with regard to timeliness. But more importantly, CMS is really now venturing into the clinical domain of a health plan and reaching really down and dictating some very serious clinical approaches for health plans, that if health plans do not follow them, there will be civil monetary fines and other implications. So they are looking at the consistent use of evidence-based medical criteria both in the pharmacy and in the medical world. And I emphasize the consistent use because CMS wants to see not only that evidence-based criteria are being used, but that it is being consistently applied to each member for each of those kinds of circumstances. Next, compliant and clear communication to the member and to the provider. They want clearly compliant correspondence going out using the correct template. They are concentrating a lot of time on, are you explaining the decision in a clear and concise manner and telegraphing what the next steps might be, for example, appeal rights, and what that member or provider has to do if they disagree with the decision the health plan made. On the model of care side, some very, very important clinical mandates have come down and will be coming down over the next few years. They're spending a lot of time looking at consistency with the model of care and to make sure that health risk assessments in care plans are done appropriately. So they are very much looking at having initial and annual health risk assessments done within 90 days of enrollment and annually thereafter. They are looking at whether or not you have actionable care plans and there are goals being set and goals that are met. And they are specifically looking very closely at the individualized care plan and whether an interdisciplinary care team is actually working those cases and are being constantly informed of changes in the member's health and the additional problems, goals, and interventions that must be taken care of over time. I'm going to move over to the right-hand side of our slide now and talk a little bit about the STAR program at CMS to show you how robust the quality regime is becoming in Medicare and why the exchange in Medicaid will look very much like this in the near future. CMS has done an absolutely fabulous job of moving quality in the Medicare program. Back in 2010, when the ACA was passed, just 14% of plans and 24% of enrollees were in 4- and 5-star plans. In 2016, those numbers changed markedly. They went to 49% of plans and 71% of enrollees. Again, an absolute success story on the part of CMS, despite some criticism along the way about their approach, which in many ways was very much unfounded. But more importantly, it needs to be understood that CMS is not resting on its laurels here and is increasing their complexity of the STAR program and is absolutely going to ask plans to continue to push the limits and increase quality along the way. So it will be more and more difficult for plans to not only achieve 4- and 5-star status, but more importantly, to maintain 4- and 5-star status. I would note that when it comes to 5-star plans, there was incredible turnover from 2015 to 2016. Roughly 50% of all plans that were 5-star in 2015 are no longer 5-star in 2016, showing how diligent a plan must be even as they reach the upper echelons of quality. I have to give CMS a great deal of credit for really creating an incentive-based STAR program. Back many years ago, few plans really put a lot of effort into 4- and 5-star because it didn't really mean a lot. Now that 4- and 5-star plans get more revenue, and that revenue must be directed into member benefits, this has really changed the focus of health plans. And health plans now understand unless they reach 4- and 5-star status, they really cannot compete in the marketplace because they will not have the type of benefits and the generous benefits to be able to attract members. And in this case, we estimate that 4- and 5-star plans have up to an 11% premium advantage on average in the marketplace over plans that have yet to receive 4- and 5-star status. I'd also note that over time, again, there's going to be increasing rigor and complexity. If you look at the proposed changes and additions in the STAR program in 2018 and beyond, the number of measures, the sophistication of those measures become much more complex, and again, harder for plans to achieve and maintain 5-star status. With that, this concludes the podcast on the emerging value-based purchasing world and what it means to health plans. I'd like to sum up here briefly about MedHOK. MedHOK stands for the Medical House of Knowledge. We offer a SaaS-based software platform that enables health plans and payers to simplify compliance and have all members coordinate care and work in one system to succeed in a value-based healthcare environment. Again, we stress the fact that our platform is out-of-the-box compliant with Medicare, Medicaid, and exchange regulations. To learn more about us, visit www.medhok.com. You can subscribe to our blogs, podcasts, and newsletters on the website as well. And you can also visit MedHOK University on YouTube. You can see our single platform in the areas it covers. Again, it's one single SaaS platform across risk, care, and quality. Thank you again for joining today's podcast. Take care.